So today is a very special IBD brief session. It's also the colorectal surgery and IBD mixer. So we're joined by a lot of our colorectal surgery colleagues. We're always happy to have you in the room, and we have special cases presented by our colorectal fellows who will present to our panelists, and we'll get your expert opinions and hopefully have great discussions about them. As a reminder, this program is funded by Pfizer. And to get started, it is my pleasure to introduce Dr. Cohen, who will be our hot topic presenter for today. He will present the refractory Crohn's patient and talk to us about stem cell transplant in Crohn's patients. Thank you so much.
Thank you, and I want to apologize in advance to people that also attend our IBD conference because this is the same talk. But I know it was a different audience, and I did not do the scheduling of this. So I think the first question we always ask ourselves is, do we really have a problem, right? You know, is this idea of refractory Crohn's, what does it mean to us as your IBD practitioner? And if you sort of follow our randomized controlled studies, beginning, of course, in patients receiving anti-TNF, and looking at what happens in those patients as they fail, what we can see is after the failure of the first therapy, no matter what we choose second and even third, there's a diminished response in our patients. And what does this look like? It would be an estimate that about 20% of the patients in the United States, or about 115,000 patients with Crohn's disease, are inadequately treated. And so I do think we have a problem with refractory Crohn's disease, and I think the issue that we all face is, what do we do with these patients? Because when we stare at them in the clinic, I think we're sort of at a loss. And I think the first help that we had came from ECHO, trying to provide us a review of how to approach these patients, and I think it is really helpful, and it's what I think about in my clinic when I see patients with refractory Crohn's and we're thinking about stem cell transplant. So the first thing is we want to define refractory Crohn's, which is really the failure or loss of response to all licensed immunosuppressors or biologics and not being amenable to surgery. And then what do we do next? And this is really the right strategy, which is to ensure treatment failure. And that's because oftentimes we deal with patients maybe not seen by people who are as experienced in IBD, or just that sometimes when this patient comes to you over and over again, we don't take a minute to sort of reflect on what's happened. And I think one of the most important things we can do is to consider restarting infliximab. And we see the data here where we see patients where infliximab was stopped in remission actually can do really well if you restart it. And that response is actually dramatically improved if we combine that with an immunomodulator. And why this happen is because this is our oldest drug. Patients were stopped for a variety of strange reasons, out of fear mainly, but also due to insurance issues and just we didn't know. We don't really have great data on restarting other drugs that may have been stopped, so other advanced therapies. We always have to consider whether or not they were dosed appropriately in the duration. And again, medications are stopped for a variety of reasons, oftentimes insurance or even social reasons. We also want to make sure that the cause of the persistent symptoms is due to inflammation. And we see here the fact that oftentimes patients can accumulate bowel damage. So we see patients sometimes where they actually have no more inflammation, they're quite sick, but it's really from strictures and scar tissue within the bowel.
Louis, can you just
Sure.
go back 2 slides?
2, done.
Is this for patients who is the response rate for people who responded and then it was restarted, not for failures that it was restarted?
So
that's what I'm,
top curve
Yeah.
on the left is
Yes.
they responded and it was stopped. The curve on the bottom, they did not respond, or actually had a loss of response,
and then it was,
or an infusion reaction. They do not do as well when you restart them.
but it seems like there is is that just immunosuppressors and not immunosuppressors?
No,
So
it's
the
This one on the left
combination.
is that,
combination versus,
Right,
but it's
combination
not,
is not.
it doesn't show.
this shows you who responded or not. So basically, you know, when infliximab first came out, we did,
I know. what we
right,
did,
exactly.
He was there at the beginning.
I know I was going to say,
I'm
yeah,
old
he's
enough.
still
This is
there.
an old study from Leuven.
Yeah.
All right, so what do we do next? This is where then we start to see people pull in a lot of off-label medications. And I think really what I want to highlight here is that these are a lot of drugs that have been used. People still talk about them today. But the funny thing is a lot of the studies were really even done before Remicade, or I should say anti-TNF, were used. So this is looking at 6TG in patients and 193 people. And while there was a decent response, it was very difficult to still maintain due to intolerance. And again, these were not, you know, sort of the modern patient. Same thing with cyclophosphamide. People think about using this. Small numbers of patients. Over time, unfortunately, not a durable remission. And again, not anti-TNF failures. thalidomide, the same problem keeps happening. I just have to like completely edit this. And the point of this slide should have been, if it projected correctly, was that no one can tolerate this drug. Everybody gets neurotoxicity. It's a really terrible drug. So what do we do next? You can refer for a clinical trial that we've shown here, that a lot of patients who really fall into this refractory category are not often eligible for clinical trials. It's about 31%, especially patients with stricturing or penetrating Crohn's. And what happens to them? They just go on to more surgeries. So again, what should we do next? And we could wait for the next drug. That's really what I think a lot of people end up doing. Now we're starting to think about this idea of these dual advanced therapies. But I really want to point out to people that's not what we're talking about in refractory Crohn's. Here are some controlled trials where they started it up front in patients who had never been exposed to either. And actually, maybe these types of dual therapies might have shown a benefit compared to either alone. But really, we're trying to think about patients that have failed stuff. So they tried to answer this in a meta-analysis. And they looked at these quote-unquote refractory patients, and they saw upwards of a 40 to 50% response. But this is where you have to dig into a meta-analysis. And if you actually take out one of these studies and you looked at the 24 patients that they referred to, 7 of them had actually never even been on one of the biologics, and 2 of them were completely new. So these were not refractory Crohn's patients. The idea that they fail A and they fail B, but A plus B is special, probably doesn't always hold true. So what do we do next? Well, what we don't want to do next is keep waiting for these patients because they could run the risk of progressing to intestinal failure. And we see that 5% of our patients go on prolonged TPN over the course of their life. And actually, in terms of the causes of intestinal failure in Crohn's disease, the rates of intestinal failure since 2010 have increased for patients due to multiple resections and refractory disease, and have decreased due to surgical complications. So good job, surgeons. We're better at not causing issues. But the idea of refractory Crohn's is still growing. And when that happens in our patients, we're looking at 13% mortality over 5 years. So we do not want to see this happening. So this is where actually ECHO did recommend stem cell transplant. But the question is, why are we not doing this? And so first off, it's important to understand that stem cell transplant is divided into 2 phases. The first is mobilization, where we collect the stem cells, and the second is conditioning, where we give the chemotherapy with the hopes of trying to deplete the resident inflammatory cells. And the way that we do these things and the drugs that we give is really what determines the safety and efficacy. But you can see here it's not trivial. We're looking at over a month in the hospital for these 2 phases for our patients. And so when we looked at the Aztec trial, which was the first randomized controlled trial across multiple sites, we want to think about those factors, right? So they got mobilized using cyclophosphamide and granulocyte colony stimulating factor, and for conditioning, they received cyclophosphamide and ATG. Patients were determined to be refractory by committee, and we think this is a critical component of this. But unfortunately, what happened was that the abstract said it didn't work, and people don't read past the abstract, and this is not true. Partly the reason it didn't work was that the primary outcome was an extraordinary outcome of combined clinical endoscopic remission and no medications. And is this really realistic in patients who've undergone multiple surgeries and had extensive bowel damage, that they're not going to have any symptoms? And in fact, when they looked at outcomes like partial endoscopic healing, we saw that almost 90% of patients had a response. And yes, this outpaced clinical remission, because again, we know that in this cohort, the idea of being totally symptom-free may not be realistic. So again, why is it not standard? I think a lot of people were concerned about adverse events. The majority of them were really infectious, oftentimes in patients with perianal disease, but these were short-lived. There was 1 death due to sinusoidal obstructive syndrome from cyclophosphamide. We have protocols now to try to reduce this risk. But ultimately, the risks of a transplant need to be weighed against the risks of doing nothing in this cohort, which again can approach 13% mortality at 5 years. So the other reason that it's not standard was that we were waiting for this Aztec Light trial. And the Aztec Light trial was promising to make stem cell transplants safer by adding fludarabine and reducing cyclophosphamide that they think caused complications. Sadly, it wasn't. In fact, there were 3 patients that had progressed to renal failure and 2 deaths due to thrombotic microangiopathy. And then this led people to call for a halt to stem cell transplant for Crohn's. The people that called for it were not Crohn's doctors, though. They were stem cell doctors. And so actually they were completely off the mark because, 1, these were complications that we knew were associated with fludarabine. These have never been observed with other protocols. So you would have assumed a stem cell transplant doctor would know that complications are related to the drugs you give. And then ultimately they failed to appreciate that doing nothing in refractory Crohn's is doing harm. right? That we have to consider these patients as being just as sick and just as needy as patients that go to stem cell transplant for other reasons. So we believe that it should be considered standard. We're trying to understand this and put this into context across an international consortium. And what do we see? We see the fact that my slides don't move forward. Let's see.
It didn't happen during ECHO, huh?
No,
Which
there
is
we go.
good.
Well, you know, the Europeans, I guess, have better technology than we do. All right. So we have about 104 patients we're collecting data on, over 10 years of follow-up. All of our patients got the same conditioning regimen with cyclophosphamide ATG. Everyone's reviewed by committee, and we looked at standard clinical endpoints. And again, these are sick, young patients. 33 years old, but 15 years of disease on average. 2 resections, a quarter of them with ostomies, 35% perianal disease. And for this initial data I'm going to show you, it's at least a median follow-up of 2 years. And what we saw was that patients continued to do well in terms of how they felt, in terms of what the endoscopic score looked like. And when we look at it visually, we can see here, this is actually probably one of the more, I should get a worse case. This is probably one of the more mild of the severe ones we saw, but we see the fact that they heal. And I think that the idea on the lower picture is you can still see that scarring, right? You can still see that pallor. You know, that's not something that we can fix in these patients as easily. But ultimately, to summarize, 72% or more of our patients were in both clinical or an endoscopic response at the time of the last follow-up. And they also felt better. They had less pain, less depression, better social roles. And ultimately, this is not a cure, right? We do see relapse post-transplant, but what's fascinating is they respond again to the medications they failed, suggesting a way that transplant really can alter the long-term natural history of this. Among these patients, we did not see any deaths, renal failure, malignancy. None of our patients progressed to intestinal failure. Actually, 3 of them were able to stop TPM. And we only had 7 Crohn's-related surgeries, of which 2 were actually ostomy reversals, so good surgeries. So in summary, you know, when we assess our refractory Crohn's patients, I think the first thing we all look to is did somebody or was there a reason that something was done incorrectly and that we can actually fix that in terms of the medications. We want to make sure that not all their symptoms is due to inflammation and maybe due to damage. And I would caution people with the idea of dual biologics in these cohorts. Stem cell transplant works. It should only be done really weighing the benefit against the safety and only performed at centers of expertise. I also urge people to refer early. It takes months, if not years, to get people approved. So for anybody who's interested, you can contact me at any time. Thank you. And we'll go into the panels. I'm on the panel?
You are.
Oh. I will not be going all
Surprise.
around.